So good evening, everyone. Thank you so much for joining us this evening. My name's Beth Ward, and I'm the Head of Education here at the RPS. And so tonight, we're being joined by colleagues from the UKCPA's Pharmacy Infection Network to run a webinar providing a bit of an update on what's been going on in relation to COVID trials and management. So it's been a few months since we've done one of these trials, but we all felt that it was time to run one of these sessions and share a bit of practice around what's going on in different parts of the country. Now, before we kick off, I'm just going to run through a little bit of housekeeping. So we do have a few slides prepared for this evening, but we do want this to be a Q&A session. So thank you to everyone who has submitted questions already, and we will be covering those as we go through the session. But to find the Q&A box, you should see on the bottom of your screen on the right-hand side, there's a little question mark icon, and if you click on that, you should see a chat box appear on your right-hand side. Now, please do type your questions into there. I'll be on hand to keep an eye on the questions coming through, and I'll be able to forward those through to the panel as we go. This session will be recorded this evening, and the recording will be made available on our Watch and Listen page of the RPS website. So that's open and accessible to everybody as part of our COVID-19 resources. So I'm going to hand over to our chair. So this evening, I'm delighted to be joined by Del Sheikh, who's an anti-infective and respiratory lead pharmacist at Portsmouth Hospital University Trust. And I'm going to hand over to Del to introduce the rest of our speakers. Thanks very much, Del.
Good evening, everyone. Thank you very much for joining us tonight. We felt that earlier on in the year when we ran these sessions, these joint sessions with the UKCPA and the RPS, that they were well attended and people enjoyed them, and we felt that it was a good time to reintroduce a few more sessions, especially now as we're seeing COVID cases increasing, and more importantly from a pharmacist's point of view, seeing the remdesivir and dexamethasone drugs used a lot more frequently. So what we thought we would do is spend a little bit of time in the session going through some of the more up-to-date trials and talk about some of the preliminary results that are coming through, and just kind of discuss some of the questions and answers that you guys have asked. So as we said, thank you to all those who have already submitted questions. We will try and get through as many of them as we can at the end of the session. And as Beth said earlier on, if you have any questions, and please put them in the Q&A session. If we have time to answer them as well, we will. A lot of the questions we've had are on similar themes, so we'll be able to cover them pretty much at the same time. So I'd like to introduce the speakers we have. We have some of our national experts on some of the topics. We have Dr. Alex Hicks, who is one of my respiratory consultants that works with me at Portsmouth. We have Stephen Hughes, who's a consultant anti-infective pharmacist from Chelsea and Westminster. We have Christine Sang, who's a lead clinical trials pharmacist at Oxford University, and Paul Wade, who's also a consultant pharmacist at the infectious disease at Guy's and St Thomas's in London. So the plan is that we're going to try and cover in the session the clinical trials and research developments, talk a bit about remdesivir for the treatment of COVID-19. We've been asked to talk just to discuss a little bit about steroids in pregnancy and children, and how we manage influenza during the COVID-19. So we'll start off with Christine, who's just going to run through an update on the recovery trial. So Christine, can I hand over to you?
Yes, thank you. Right, so the recovery trial. Oh, can you see the slide, please? So for the recovery trial, just a quick update on what this is about. So any patients who present into hospital who are COVID positive or suspected of COVID can be randomized or can be recruited into the recovery study. So patients initially can be randomized either to receive azithromycin or standard of care, or they can then simultaneously then be randomized also to receive covalent plasma, or this new arm that we've recently added, which is a monoclonal antibody called Regen 2. After this randomization, if the patient is sick enough, then they can then be randomizing to the second phase of recovery, which is tocilizumab or no additional treatment. So then just to give a quick update about the new arm, which is the REGEN-COV-2, which is a monoclonal antibody. So the SARS-CoV-2 has spike proteins around the outside of it. And it's thought that these proteins then bind to the ACE2 receptors inside the body, and then the virus is then taken up into cells and then replicate. So the aim of these antibodies really is to bind to these spike proteins to prevent the uptake into cells. So there's a hope with REGEN-COV-2 because it contains 2 different antibodies, that if, say, the virus were to mutate for whatever reason its spike protein, that if, say, one antibody doesn't bind so well, that the other antibody probably will still bind, and therefore it will still work and hopefully neutralize the virus. And as you can see from the news, that the most famous person so far to date is Trump, who received this antibody. Thanks. And that's my update for recovery. Thank you.
Thank you, Christine. So the next update will be Dr. Hicks talking about Stop COVID-19 trial and the REMAP-CAP. Alex, hand over to you.
Yeah, thanks very much, Dale. I'm Alex. I'm one of the respiratory team at Portsmouth Hospital. I'm going to talk about 2 trials that I'm aware of because they're running at Portsmouth as well as recovery, so REMAP-CAP and Stop COVID, but this isn't kind of a full overview of all the different trials that are ongoing in COVID at the moment, and you may well be aware of a variety of different ones in your own trusts where you're working at. A couple, before we move on to REMAP-CAP and Stop, that I would like to point out just briefly, because you're more than likely to come across them, are the Principal trial, another study from Oxford. This is the primary care platform, so where recovery sits in the middle, people that are in hospital haven't quite made it to ITU yet, which would fall into the REMAP-CAP setting. Principal is for people in primary care, and it's looking at a variety of different drugs. It was originally around hydroxychloroquine, when that was Trump's favourite thing at the time. But it is still ongoing, and as I understand it, is currently separating people out to either azithromycin or doxycycline treatment. But again, because it's a platform trial, that will change and can be adapted over time. The other one to note, I would suggest, is the Accord study. So this is one that's running out of Southampton, but will have probably 10 different centres across the country. And this is trying to look at drugs that where we've taken off-the-shelf medications so far, in a lot of cases, things like dexamethasone or hydroxychloroquine. These are the new novel treatments and a variety of different ones that are going to go into that study. And I think people will start to see more of those and be made more aware of them over time. But Dale, if we could move on to the first slide with REMAP-CAP, please. Thank you. So REMAP-CAP is just as a bit of a background, is an interesting setup. So actually, this has been set up for a long time to run in ITU departments with the idea of looking at community-acquired pneumonia and how that's treated in ITU settings. It's a platform study, so the idea being from that you can have a variety of different treatments that are all being trialled at the same time in the same illness, and you can compare them in a head-to-head way, and also against placebo. It had a sub-arm around looking at infectious disease outbreaks, so that fitted in nicely with COVID. So they developed a COVID sub-protocol. And it has different arms, as with recovery, looking at different domains. They tried to kind of block them into certain themes. So there's immunomodulation, being interferon beta, IL-1 blockers, tocilizumab with IL-6 blockers, as with recovery. There's an antibiotic section, an antiviral section, much of which has already been disproven with hydroxychloroquine and so on. They had a steroid arm. They were using hydrocortisone as opposed to dexamethasone for recovery. I don't think there was a specific reason why they chose that over dexamethasone. They've introduced a newer, more recent arm that is being seen more in our trust, certainly as the second wave is coming through, and that's looking at anticoagulation. There's big issues around microvascular thrombi and bigger thrombi, thrombus disease in people with COVID, so that's an interesting arm. And there's also a ventilation strategy section. I missed off a wider ventilation issues that they were looking at too, as well as just drug treatment. Next slide, Del. And then another study that we're running in Portsmouth currently. This is Professor Chalmers' group from Dundee, Stop COVID-19. This is looking at, this is one that I can never say very well, but brenzocative. So it's an inhibitor of DPP1. So it's the idea being it's targeting neutrophils. Activated neutrophils thought to cause much of the unintended damage within the lung. They're great for killing off bacteria, but in a viral illness like this, they can be overactivated and cause some of the progressive lung damage presumed from COVID-19. Interestingly, the way they work is actually to alter the way that neutrophils are matured in the bone marrow, so actually take a few days before they'll have an effect. Okay. Next slide down. So this is again running across 10 sites in the UK. Slight difference to this as some of the other trials is that this is a month-long course, and that reflects the fact that it actually takes a while to kick in and be effective. So people are going home on this study drug, and that has got implications for anybody any pharmacy teams that are running this around the country, because unlike things like recovery, where a lot of the work stops as soon as they go home, this is one that continues on and needs a bit more. Thanks very much.
Thank you, Alex. And then the last trial we were going to just mention briefly was the adaptive COVID-19 treatment trial, and I'll hand over to Paul for that. Thank you, Paul.
Thanks, Del. Yeah, this was just going to be a little bit of an update on two studies actually that have been published recently. So if you could move on to the next slide. So ACTT1, or as Del has said, the adaptive COVID treatment trial. This was one of the first studies that actually managed to reach the press earlier on this year as a preprint, and has finally, in its final report, been published just a couple of weeks ago now, in fact, 13 days ago. So this was remdesivir for treatment of COVID. What they were looking at as their primary endpoint was recovery in terms of clinical recovery at 28 days, or a secondary endpoint was clinical recovery at 15 days. That was the initial primary endpoint, but there was a rethink early on in the trial to adjust the endpoints to account for new knowledge about the course of the disease. In terms of looking at some of the demographics for the patients, then I've just kind of taken a little snapshot from the New England article with the you can see the DOI there in the top corner. Really, the groups were very well matched. It was remdesivir against the placebo. Reasonable numbers of patients, so 500 in each arm. Well matched in terms of the patient groups that we're looking at, and then you can see they use these stratifications in terms of clinical severity of disease at the time of randomization. So there are a range of different, as they called it, an ordinal scale ranging from 1 to 8, and really one of the things they were assessing was how people progressed along that ordinal scale through the course of the disease. So you can see again the breakdown in terms of the more severe end of things there, in terms of patients either hospitalized not requiring supplemental oxygen, which is a scale 4, hospitalized requiring supplemental oxygen, which is their scale 5, hospitalized receiving non-invasive ventilation or high-flow oxygen, which is 6, and then hospitalized receiving either invasive ventilation or ECMO, which is 7. One of the things to consider clearly now as we learn more about the diseases are the co-treatments that might be given alongside some of these earlier studies. And in this particular study, 35% of the patients received hydroxychloroquine at the same time as they were receiving remdesivir. 23% received a steroid. Much of the sites that recruited for this were in the States. So again, I think as Alex has alluded to, the Trump effect would have had a bit of an impact on that co-administration of other agents. Next slide, please, Del. So just looking at some of the results here, it's probably a slightly difficult slide to read unless you're maximizing your screen. But what we can see with the results in terms of the overall performance for the study is that the mortality, which was not one of their primary endpoints, their mortality data showed a slight suggestion towards a benefit with remdesivir. You've got a hazard ratio of 0.73, although it does cross the 1 line in terms of the total group. But if you look at the different subgroups, depending on which ordinal score they were at baseline, so 4, 5, 6, or 7, as I've just described, there is again a suggestion, and again, remember, this was not a primary endpoint. There's a suggestion of mortality benefit with remdesivir versus placebo in the ordinal score 5 at baseline, which is that patients who were hospitalized and requiring oxygenation. There's not really enough numbers in some of the other groups, particularly in 4 and 5, 4 and 6 to really show a benefit. And again, in 7, although there were more numbers, not really much there to show a benefit in terms of mortality. In terms of the outcome data, then it was shown that within the study that remdesivir was superior to placebo in shortening time to recovery. So time to recovery, the remdesivir arm, total arm was 10 days versus 15 days for the placebo arm. And again, there was a greater improvement in those who scored 5 in this ordinal scale at baseline. Similar results regardless of hydroxychloroquine or steroid usage. So neither of those 2 co-administered drugs seem to make any difference in additive effect with remdesivir, and we know now from some of the other studies which have been published since that certainly around hydroxychloroquine that makes sense. And if we can look at the Kaplan-Meier curves on the right-hand side, then you can see again the recovery scores at 28 days. You can see a slight difference overall between remdesivir and placebo in the top slide, and a slightly larger difference between remdesivir and placebo in the bottom slide, the bottom graph, which is C, which is specifically those patients who are on hospitalized requiring oxygenation at baseline. Those are the only 2, I've censored the data slightly there, those are the only 2 that show any kind of difference between remdesivir and placebo in terms of the way that the results were shown, depending on the ordinal scale at baseline. Off the next slide, please, Del. And more recently, the Solidarity study, which is another platform study, not just talking about remdesivir, but covering a wide range of other agents, so including hydroxychloroquine, lopinavir, ritonavir, and also interferon, has just been published as a preprint, so just about 10 days or so ago. So this is a much larger study in terms of patient numbers with a much larger geographic spread covering all 6 continents. And then associated with that, there'll be some questions about the consistency of the standard of care, which was the comparator being used here against the active agents. And it ran all the way from March to October. And again, so there'll be some questions in terms of validity about changes in practice and people's knowledge about the disease and ability to manage the disease over that period of time. Just for a comparator, the ACTT1 study first recruited on February the 21st and closed recruitment on April the 19th, so a much tighter time period, much more likely to be a fairly similar patient cohort and underlying management of those patients than a study that's run over a 6-month period with a disease we're rapidly gaining more knowledge about how to manage it and how to manage those patients in terms of standard of care as well. But that notwithstanding, there's significant numbers of patients in the remdesivir arm here. We're talking about over 2,500 compared to the 500 in ACTT, and that compared with an relatively equal number of controls. On the right-hand side there, you can see a table with some entry characteristics in terms of how well matched the two groups were in terms of the remdesivir data, and across the whole range of the Solidarity study. And there you've got a forest plot which shows, again, some of the potential benefits in terms of remdesivir. Mortality was one of their main endpoints to look at here. Initiation of ventilation and length of stay were two of the other main endpoints. And you can see that there's no significant difference between remdesivir or standard of care in mortality for any of the age groups that they looked at there, and whether patients were ventilated or non-ventilated. There were suggestions that patients who were ventilated at entry do worse with remdesivir, and slight suggestions that patients who were non-ventilated at entry do better. But certainly in terms of the significance of that, that's not been shown here. Next slide, Dale. And just to show that again in terms of Kaplan-Meier curves, that's remdesivir versus control in the left-hand side for the whole group. And really that's just an expanded version of the lower graph there in the top right-hand corner, showing really that those two curves are pretty well matched. And on the right-hand side from, I think, if I remember correctly, this is from the supplementary material, there's a Kaplan-Meier there looking at ventilated versus non-ventilated patients in terms of mortality. And as you can see, the lines for remdesivir and the control do start to pull apart in the ventilated patients, but are pretty similar in the non-ventilated patients. So main conclusions here were remdesivir has gotten little or no effect on hospitalized COVID-19 in terms of mortality, initiation of ventilation, or length of stay, and subgroup analysis showing that remdesivir may give worse outcome in patients receiving ventilation at randomization. But that wasn't significant, and that wasn't powered for, in particular, as an endpoint. So that's just really an update for both of those. Next slide. I think really the questions now are, where does that leave us? And one of the useful things that Solidarity provided was it provided a slide or a table, a forest plot that compared Solidarity, ACTT, one of the earlier Wuhan studies, and the simple Gilead study, 5 days and 10 days of remdesivir. And really it just kind of adds to the data set that we've got now about remdesivir, suggesting that there's no great benefit for remdesivir in terms of overall mortality outcomes. There may be a subgroup who are on low flow oxygen that might potentially get a benefit, and you can see the large black box at the top there is that group, but again it crosses the line. ACTT, which was much smaller but wasn't powered for this, which is a mortality forest plot, does show a better outcome around low flow oxygen, but as I say, it wasn't powered for that. There's a suggestion of potential harm, perhaps in terms of adverse outcome with patients who might be on high flow oxygen or mechanical ventilation, but again a suggestion, and neither of the studies were powered for that. And one of the things about all of these subgroup analyses is actually trying to, if you start trying to think about them in isolation, you can't think about them separately from each other or from how the other patients within those cohorts were managed. So what will the impact of this be on practice and policy? Well, it's difficult to say. I know that the commissioning policy is under review at the moment to potentially take into account the final publication of ACTT and also the data that's now come out from Solidarity. Will this impact at all on the conditional marketing authorization? Difficult to say. That's a hard decision to make. Can anything be done really until the full Solidarity results are available? Probably not. What will this mean for usage of remdesivir in the UK? Again, difficult to say. And obviously some of this is all dependent on actually what is the supply of remdesivir like at the moment. And again, that has its regional variations as well as its variations across Europe as well. So there's a lot of unknowns. But this is the data, and it's an increasing amount of data now that we have. This is the data that we're seeing. So thank you. Thanks, Dale.
Thank you for that. Thank you for everyone. So those that's a bit of a recap on the trials. And I think for the rest of the session is more of a discussional session to discuss questions that we've had and questions around COVID and COVID treatments. One question, if I may, Paul, has just come through on the Solidarity study. It was the control actually is a combination of the number of actives. So remdesivir, is it no better than other active treatments? Do you want to comment on that?
I do. I'm just actually cheating and looking at the preprint at the moment. As far as I'm aware, patients were randomized to each of these different agents. So this was not, as far as we know, this was not a comparison between remdesivir and patients who might have been on hydroxychloroquine or lopinavir. This was standard of care. There may, of course, like there were in ACTT and there are in the other studies, a small number of patients may get started on one of the other comparators at the same time or during the course. But this was against standard of care. And of course, standard of care varies. Standard of care will vary across those different organisations within the country, but also different regions within countries and different countries within the study cohort. So clearly there's a lot of heterogeneity about the comparator groups, as there would be about what the other elements of standard of care were at the same time with the active treatment. So I think it's difficult to say really how it's difficult to say how strongly we can take this data because of some of the questions about the validity and the consistency of the data, I think. But certainly it's not a combination of a number of other actives as far as I'm aware.
Thank you. I mean, I think the question on everyone's mind is right now, stocks are limited of remdesivir. There's not plenty. COVID numbers are going up. The amount of remdesivir we're currently using is going up. Just want to ask the panel their opinion on what they think. Is there certain patients that should be prioritised on who should get remdesivir, or should we not be using it due to the Solidarity trial, or it's just really a question for discussion. Anyone want to comment?
I probably want to add a little bit. I mean, there would be some biological plausibility to why people do worse if they are already unwell when they start remdesivir, for a couple of reasons. Firstly, remdesivir, from personal experience and from its own data, suggests that there are issues around people developing liver derangement and renal issues, and a lot of people that were very sick with COVID on ITUs have had issues of going into renal failure, so there may be a degree of crossover into that. Secondly, its mechanism of action is around the virus itself and trying to control that. So by the time you've got to hospital and you're sick enough to be on a lot of oxygen, most of those people are in that position not because of the virus itself, but because of their immune-mediated pathways that come afterwards and overactivation of those. So you might have missed the chance for remdesivir to have had a role. So again, to come back to your point, Adele, when would you think about using these people? I would be using this in individuals. I'd be very loath to use them on people that are getting sick already in hospital. I think they might have missed the boat there. But I would echo the point already been made that until we've seen the whole study data, tying any firm decisions and saying whether this is a definite no or a definite yes to its use across the country, it's too early to say. And I don't see how the proposed panel can make a comment, or NICE can make a comment on whether we should be using it yet. One thing just to throw out there, it's nearly £1,800 a go treatment, so it's a lot more expensive than dexamethasone. I'd want to be pretty convinced that it's working well before I start giving it to everybody that comes in with COVID.
Thanks, Alex. Anyone else want to add to that?
Hi, Del. Yeah, we've had a very similar approach to what Alex has outlined. It's still, used in line with the CMO advice. I think we've all seen the Solidarity study, but we're waiting for the full publication before we act, and I imagine the CMO will update advice accordingly. We are trying to use it as early as possible, to use it for its sort of maximum antiviral effect. So within 10 days of first onset of symptoms is where we try to prioritize its use. After 10 days, the anti-inflammatories will probably have more benefit to these patients. And I suppose the contradictory evidence would be that the Springer study from JAMA from probably August, where they use it in patients coming in relatively well with oxygen requirements of minimal oxygen requirements or SATs of 94% or greater, they failed to show benefit in one of the two arms. So that has sort of complicated things earlier. So we're using it in line with CMO, patients on O2, patients who we think are going to decline and heading up to ITU. I think we're sort of prioritizing at the moment. But once they get the ITU, once they need ventilation, we are not using it. But yeah, we'll wait to hear what the CMO update says on this.
Thank you, Stephen. Anyone else? We can always come back to it. Next question I wanted to ask the panel is something that's, I think, it's been confusing me as well. Is obviously there's lots of trials going on, as we've just heard. Certain patients are put on 2, maybe 3 different trials, and the question is how is that appropriate? Because suddenly if you start putting patients on more than one trial, you're almost creating 2 or 3 different arms. Does anyone have an explanation to why, if that's okay, or?
Adele, I'm happy to take that. We've been discussing this very issue locally at the Chelsea and Westminster hospitals. We're doing a single centre study using favipiravir, which is another antiviral licensed for influenza in Japan, but has some in vitro activity against COVID-19. And one of the challenges we've been posed is remdesivir has almost become standard of care as of dexamethasone, and how we combine this study with standard of care. So we have in fact patients on 2 different antivirals, remdesivir and favipiravir, depending on randomization. So this is a challenge, how we see the benefit of one therapy over another when you see multiple therapies together. We've all been asking ourselves this question. We do not have an answer. I'll be quite keen to hear from the panel what their views are on it, or even from the wider group on the line. But yes, I think we sort of discussed this in April last year. It will make the interpretation of these studies challenging, and I think Paul has sort of explained some of the nuances between the open platform studies and the closed randomized control trials, and the difficulties in picking these apart.
Thank you, Stephen.
I'd echo those points. Though we've already talked about this. There is that fear. I mean, some of the studies are linked together, so there is understanding within the studies themselves that there will be crossover. So stop COVID to recovery and to remap CAP, there is agreement between all the studies that this is allowed and to be understood. I think this will have an impact over time as well. So as Paul alluded to when he was talking about solidarity, almost the data that you're getting is changing on a monthly basis because what is standard of care changes. So once you run these studies for 6-7 months, there is such variety in what a person has had as their standard care. So it will make interpretation of data harder and harder. I'm not sure we're going to get such a clear signal again as we had with dexamethasone right in April.
Thank you. Any other one else want to comment before I move on?
I just want to say that I agree with the others on this, that interpretation of data is going to be really hard, especially when one is between studies, especially from something like recovery to remap CAP. And I suppose it's making sure that the data collected and everything is written in quite clear detail to say, what the patient had for which study. And so I think that the doctors who are randomizing these patients need to be looking at, which arms are the patients going into, making sure that they're not going on to duplicate arms, providing sort of the same class of drug for that patient.
Yeah, thank you. I kind of agree. I think it's very difficult to put patients on, one drug and then another drug, and it just, which one is the drug that's working. But you on the flip side, if you are running the study, you want to get as many patients as you can. And is it fair, and so by doing that, they're using the same patient for several studies, but it gets very difficult. I've got quite a few questions on the steroids, and so I'm going to ask. I think we'll go with those. I'll ask all the questions, and then we can discuss the answers. So one question is obviously about when do we use steroids in pregnancy in children. The other question is about hydrocortisone dosing, which is a bit confusing. The WHO suggests using 3 times a day. The CMO suggests, another trial suggests uses 4 times a day. And so it's just really what is the right dose of using hydrocortisone. I think the suggestion was to use the equivalent of the dex dose in hydrocortisone terms. And the other question was about risk benefits of giving dexamethasone to hospitalized patients who are not on oxygen. Do you think there'll be any advantage to that? So 3 questions. Anyone to answer any of them?
Hi, Del. I'm happy to talk to the steroid recommendations, particularly in pregnancy. I think this message has evolved over the summer from the initial CMO letter post-recovery in June. They recommended dexamethasone 6 milligrams, as we know, plus either prednisolone 40 or hydrocortisone intravenous 80 milligrams twice a day. The REMAP study was sort of then closed up, and they presented their data. They used slightly different doses of steroids in their arms. They had a high and a low steroid arm, 50 to 100 milligrams TDS. They also allowed for a slightly higher dose in patients who were behaving almost like a septic picture. So I think based on a sort of pragmatic review of both these studies, the most recent CMO letter from September advises, again, dexamethasone first line, and then to use hydrocortisone and rounded up to a 50 milligrams TDS. So it's pragmatically almost identical to the dexamethasone. If you're being pedantic, you could use 160, but I think we're all very comfortable using 50 TDS in practice. And the REMAP didn't show any additional benefit using the high dose dexamethasone. In pregnancy, the ORCOG have come out with advice saying that steroids can be used. We've been using dexamethasone for years in the 3rd trimester with no concerns. So in local practice, we're still using dexamethasone in pregnancy, but I know local colleagues within nearby trusts are using hydrocortisone. In my mind, either agent could be used. We have stopped using prednisolone outside of the pediatric population, which is a slightly different issue, where we're looking at the pediatric inflammation multisystem syndrome, often coexisting with the COVID presentation, and that's almost a different discussion again.
Thank you. And so that's the 2 questions. Anyone want to answer if there's any benefit of using dex for patients not on oxygen? I'm not sure if the evidence is out there, but any comments?
I can jump in again.
Yeah.
I was going to say, on the sub-analysis, we don't have the slides, but was there, similar to remdesivir, was there a trend towards worse outcomes in patients with no oxygen requirements with steroids? I don't have the slides to hand.
I put the slide up for you before, Del. I think if you scroll down, it's a bit further on. The it wasn't just a trend. It was if you did well, yeah. It does cross one, but there was the suggestion that if you weren't receiving oxygen, you were on the wrong side of the line if you got steroids. So certainly our local practice is not to give steroid.
Yeah, that's the same with us, and it's almost become like a steroid stewardship, where we are sort of stopping steroids in patients who are started on them over eagerly, and we've updated our local guidelines to replicate this slide actually and show that there's a trend towards worse outcomes in patients not receiving O2. So I think when the first recovery trial information broke pre-publication, there was a lot of interest, and I think there was a lot of exuberance for prescribing steroids. We've had to sort of correct that with another one of our stewardship activities now is stopping steroids in patients who do not need it.
I guess that leads into another point around people going home on steroids and whether you give 10 days. My understanding of the recovery trial was that, well, the way the recovery works is that you don't go home on any of the medications. So if you're going to be discharged, we're also stopping patients dexamethasone, even if they haven't gone for a full 10 days. And I don't know across the panel whether you have similar experience.
Hey, it's Paul here. Yeah, I mean, I'd agree with that. I think that the trial was quite clear that medication should have been stopped on discharge. And I think that initially is what clinicians were doing in practice, but certainly there now appears to be perhaps an increasing trend for letting that slip and continuing steroids post-discharge. And there's also thoughts being given to earlier initiation of steroids, perhaps out in the community, to maybe prevent admission in patients who might be deteriorating potentially before they get into hospital. And I think that's certainly something that we need to be aware of and need to watch out for.
Thanks, Paul. The other question I had about Dex coming through is about switching patients. So patients who are long-term steroids for some reason, for arthritis or rheumatoid, or and then we switch them to Dex. How would you switch them back?
Stephen here. I would personally, if they're on a equivalent dose of less than 6 milligrams of dexamethasone and they're stable, they do not require steroids for other reasons. The exception would be patients who continue in ITU with almost like sepsis-like syndrome, where they require steroids for noradrenaline purposes, or for the majority of patients. However, I would happily step them back down to their standard maintenance dose as long as that's less than Dex 6. I wouldn't, or we have not been weaning patients at present, and we have not seen any detrimental complications, but it's quite a small sample size.
Yeah, I would agree with that too. I think we've just been dropping them straight back. It's only a 10-day course, and in most cases it's less than 10 days. Right, are those all my questions on Dex? Yes, so the next question I have is about anti-IL-6 therapy. Has anyone got any thoughts about tocilizumab?
I don't know if Christine wants to comment, but certainly it's part of recovery still, and they've come out with a statement suggesting that it's going to remain in recovery because there isn't sufficient patients recruited to make a comment. There has been some data published suggesting that it doesn't have an effect, but relatively small numbers and relatively small trial settings. So I think the decision is not there yet to be made. Certainly, we're not seeing lots of side effects as a result of it.
Yeah, no, I would agree. Unfortunately, the recruitment of numbers into the recovery trial after the initial, first 2 months or so, has sort of tailed off. So we do need, in this sort of second wave that's coming or is already arrived, for people to really push with recruitment and getting these patients into studies so that we can answer this question about whether these IL-6 drugs actually, are beneficial or not.
Yeah, and I assume it's for these patients. These are the ITU patients that have some degree of cytokine storm. Is that my understanding of tocilizumab?
It's not just ITU, so it's people before they've got. It's based on degree of inflammation. So if they're deteriorating and their CRP is above 75 in recovery, it's part of REMAP-CAP as well, and they've got a second IL-6 antagonist, darolutamab. I haven't used it personally, but a similar idea.
Great, thank you. Any other ones with comments?
Just to add, hi, it's Paul here. Just to add, there's a couple of studies that have just been published in JAMA Internal Medicine earlier this week on tocilizumab, showing no benefit over standard of care in patients who were either on ICU or in patients requiring oxygenation who didn't get to ICU. So I think again they're relatively small numbers, a couple of hundred, I think. Patients in total, but again, it's still we're waiting for that definitive study on tocilizumab.
Thanks. So those are the pre-plan. Well, the questions coming in from when people registered. So I've got some questions coming in from today. One I think is probably Christine for you. It's about the recovery trials. Are there any data showing how azithromycin can prevent COVID in related respiratory complications?
So I think the inclusion of azithromycin in the recovery study is for its immunomodulation sort of effects, in the hope that it would decrease the production of pro-inflammatory cytokines and the inhibition of neutrophil activation. And in terms of whether there's any studies out there that have proven or disproven whether this works or not, I don't know, I have to be honest. That's why we've chosen it.
From memory, and this is stretching it back a bit now, there was, wasn't there a French study from March, April time suggesting that azithromycin had an effect, but it was relatively small, and that's how it became part of recovery?
Oh, don't go there, Alex. That's the Didier-Raoul study, isn't it? Where 6 patients happened to get azithromycin at the same time as they were getting hydroxychloroquine. Not call that science, I don't think.
Any other comments on azithromycin? No. Another question I've got coming through are any of the panel members aware of indomethacin being used in the early stages of COVID-19?
I'll go there and say no. It's Paul. No information on indomethacin at all that I've heard of.
I'm going to echo that, saying not heard anything from it.
Same for me as well. I haven't heard anything.
Yeah.
No, I haven't heard that either.
Yeah. Same here. What about vitamin D? Is there any evidence about patients having vitamin D supplements or more time in the sun? But there's been lots of things about increasing vitamin D. Has anyone got any comments on those?
I've not seen any publications on the matter. There has been a lot of interest in vitamin D, vitamin C as well, but I've not seen any publication. I'd imagine with all the isolation and lockdowns that we all are probably vitamin D deficient, and there has been some work giving staff members vitamin D in the NHS trusts due to the increased workload and reduced exposure to the sun. I've not seen any outcomes from these studies. The other panel may have more info.
I have to say the same as you, Stephen. I've not seen any studies either on the use of vitamin D, but I just heard things in the grapevine, I think.
It's Paul here. I mean, there's been lots postulated about vitamin D and reduction in respiratory tract infections, particularly viral respiratory tract infections. And I think there have been some reasonably big studies that have shown a a suggestion that increasing vitamin D levels or providing vitamin D supplements might reduce the risk of contracting some respiratory tract infections. But I don't think anything has been tied to COVID as yet with vitamin D. I think that where all the interest in vitamin D has come from is from that extrapolation from, well, it's a respiratory tract infection, so maybe vitamin D can help. Probably Alex has got something to add as a respiratory physician about the benefits or otherwise of that. Thanks.
So there's lots of supposition about the role of vitamin D. All the studies that have been published in kind of separate areas, of be it TB, be it COPD, be it asthma, rely on you having pretty low levels of vitamin D before there's much effect. I am just struggling to find, because one of my colleagues is very keen on the use of vitamin D in COVID and keeps on telling me that there's studies out there. I haven't read or seen them to be confident to say one way or the other, I'm afraid. So I will sit on the fence on that at the moment.
Thank you. I've just realised we've not asked question 4. So this is quite interesting at this time of year. So patients coming in to A&E, we don't know if they got flu, whether they got COVID-19. How is everyone managing this? And also, has anyone come across a patient who's been tested flu positive and COVID positive? Do you treat them, or if you have, do you treat them with Tamiflu and remdesivir?
Hi, Dale. We have not seen any patients as of yet, as of this morning, with co-infection of influenza and COVID-19. We screened all our patients in the initial period, February, March and April last year. Over 300 patients tested with COVID and for influenza, and there's no positivity at all. And the data from south of the hemisphere from their winter period shows very little influenza circulating in general practice. So I think with all the lockdowns and masks, the influenza has taken a hit, certainly in Australia last year. In practice, we've changed our guidelines slightly. We screen first for COVID and for influenza, and if the patient is influenza positive, then we treat. Previously, we would have treated empirically if you have influenza-like syndrome. We would put you on Tamiflu from the off, and then de-escalate if you're negative. Now we sort of slightly switch it around, so we do not start therapy. We test you, and if you're positive, then we go on and start therapy. But as I said, we've had no positive cases with COVID to date.
Any other comments, Alex?
We're in a similar position, so you're aware we haven't had any influenza as yet this season. I'm hoping the same thing will apply to us as they saw in Australia over their winter. We didn't have any co-infection, but I think COVID didn't really arrive in Portsmouth until perhaps later than you saw it in London, so I wasn't expecting co-infection together. We are starting to test for both. We will see what happens.
Thanks. I know in Portsmouth, our testing is probably the same as everywhere else. It's quite rapid, so we can get away with testing and waiting for a positive flu before we start Tamiflu. Anyone else want to comment on that?
Hi, it's Paul. I just echo what Stephen said. I mean, so far we've had very few flu cases, at least in this season, i.e. the one that's just beginning now, probably only a handful. And we've not seen any co-infection as yet. And clearly one of the hopes is that we get a mirror of the southern hemisphere experience with much lower flu rates to take some of the pressure off of inpatient beds. That would be really great if that happens.
And then just to echo the same for Oxford as well, as far as I'm aware, we haven't had any co-infections either.
It's good to hear. Just had a message from Kerry to say that NICE have said there's no evidence for the use of vitamin D, so just to continue to use vitamin D as normal supplementary usual practice, it says, but no evidence to benefit. Another question just come through about statins. what about statins? PJ suggests improved outcomes in those on statins, but should be starting a statin in positive. But should we be starting patients who are positive with statins? Anyone got any comments?
Stephen here, we wouldn't be doing it in practice. We haven't seen the evidence. There has been a lot of reactive practice. Initially in April, May, we had our geriatric consultants going around stopping everyone's ACE inhibitors and ARBs. And then a few months later, they're restarting them again. I've not seen any evidence to change my practice. So if you need a statin, you get a statin. If you don't, and it's just for COVID, we would not be advocating the use of statins locally.
Agreed. Same here. Is anyone else using statins in their places on the panel?
No change from us.
That's a no from Guys and St Thomas's.
Just looking at the last few questions. I think we have answered all the questions come through. If anyone's got any last minute questions, send it in now. Otherwise, I think it's 4 minutes to 8, so I think we can wrap this up. And I'd like to say thank you to all of you guys on the panels. Thanks to Paul, Stephen, Alex, and Christine. Thank you to Beth for being our host and organising the session. And thank you to all of you for registering and joining us today. I hope it's been useful. We have another session in 2 weeks' time on Thursday. Stephen, do you remember the date? Is it the 5th?
The 5th, yeah.
5th, thanks, Beth.
Yes.
5th of November, which is on antivirals and antibiotics use in COVID-19, which will be hosted by Stephen Hughes. I would like to say thanks again and hand back to our host, Beth.
Great, and thank you, Del, so much for chairing the session this evening. I think it's been a really good discussion. We've had lots of questions that have been answered. So, as Del said, if you do have further questions, please just don't hesitate to send them on through, and we'll look to see if we can answer them either and put links to resources on the website, on the RPS website, or look to see if we could answer them during the next session on the 5th of November. So as I said at the beginning, there'll be a recording of this session that will be available on the Watch and Listen page under our COVID-19 resources that are open access for all professions, and we will be sending out a link to all of that to everybody who's on the line now as well. You'll also receive a feedback form, so please do use that to send through any questions or any suggestions for further sessions that you think would help you in your practice during these winter months. So 3 minutes to 8, so I think you've all got 3 minutes back, so a huge thank you to you all, and I hope you have a fantastic evening, and we hope to speak to you on the 5th of November. Thank you very much.
Thanks, everybody. Good night.
Thank you.
Thank you.
Bye.
Thanks, everyone. Good night.
Thank you.